lovely turnout, so thank you for coming. THETA asked me to specifically focus on sort of some ethical controversies in the context of genomics. Of course, that could be a full year course because there have been multiple and long-standing and persistent challenges in this field. So I'm going to try to focus the conversation on really one particular issue, which invokes a lot of other ethical principles and issues rolled up into it. So hopefully that will give you a bit of a flavor of a bunch of different issues that are focused around one particular controversy. A couple of weeks ago, Wendy gave rounds here at THETA and really sort of set this up perfectly because I think she introduced you to some of the opportunities and challenges in this field from an HSR and economics point of view, and the ethics issues really sort of map into some of those challenges quite well. So I'm going to give you a very quick primer on the technology. I'm not going to spend time on that because it will just detract from the other issues. I'm going to describe sort of the core ethical debate as I see it. We've been sort of living in the last year or so. And I'm going to describe to you our experience at ScM with how we've sort of grappled with the controversy, how we've implemented a particular approach to it, and how we've generated some preliminary qualitative data from parents and healthcare providers around how they're sort of interacting with the particular structure that we've developed. So as most of you know, well, actually, I don't know what background people have in genomics, but I think you're hearing a lot about it. If we think of the genome as made up of two fundamental components, the exome, a set of the exons and the introns, you can see the yellow and white blocks there map the depiction of the ways in which genetic information is mapped along a chromosome. The yellow blocks represent the exons, and the exons, or the exome, the compilation of all the exons, are the parts of the genome that make proteins and comprise about 1% to 2% of the entire genome. Most known disease-causing variants are located in the exome. So you hear about whole genome sequencing as well as whole exome sequencing, and it's really the exome that houses most of the disease-related variation. An exome sequence itself identifies about 20,000 variants once it's gone through the bioinformatics step. Compared to a genome, which is the combination of the exon and intronic material. In the intron, there's a lot of regulatory processes that regulate what happens in the exon, which is why there isn't a lot of disease-related content there, but it makes up the majority of the genome. And a genome sequence identifies over 3 million variants. So just as you can picture, you hear about analogies with books and words on a page. If you think of an apple, and the slice of the apple is really the exome contained within the genome. In the current day, falling technical costs of genomic sequences, combined with increasingly capable bioinformatics pipelines and software, creating a lot of increased opportunity to use this technology. And it's really entering medicine in a lot of different areas, very translational at this point in time, but it's still starting to insert its tentacles in a lot of places. Some of the core areas in which that's happening is in the context of characterizing rare disease. So because it's able to examine the genome at the highest resolution we'll probably ever be capable of doing so, it's thought, and as we're demonstrating certainly with some preliminary evidence at SickKids, that the diagnostic yield is actually much greater than with traditional techniques. So better understanding the genetic etiology of rare disease that current technologies or past technologies have yet been able to identify, individualization of surveillance and treatment plans, so identifying druggable targets, tailoring medication regimens according to genotypic findings. That's been an area that's really developing. In the prenatal screening space, whole genome sequencing is not there yet, but what is there is a technology that can identify fetal DNA in maternal blood. So it's something called non-invasive filtering, which is now available in Ontario and in many parts of the country, where women no longer need to have an invasive amniocentesis, which confers a miscarriage risk, to identify fetal DNA. So currently, you are able to identify chromosome abnormalities with that technology, but I'm sure before long, not before long, there will be the capabilities of gene sequencing in that space too. And in the kind of population screening, in the area of newborn screening, so newborn blood spot screening is a public health program that's been in place since the 1960s. That has used a lot of biochemical testing to identify rare disorders, and now many of those programs and the NIH has sponsored multiple programmed to start to translate their technology and start to implement some of the capabilities of whole genome sequencing in that context as well. So in addition to all of these opportunities for use, we also have an increased set of ethical challenges. Many of these challenges are an extension of existing ones, so we're still faced with challenges around genetic privacy, around equity and access, around managing family dynamics and communication, around concerns related to insurance and employment discrimination and who is able to ask for and who must disclose what genetic information, issues around testing minors. Should we biobank? Do we need to obtain consent for biobanking? To what extent can we use samples that are biobanked? Do we have duties to warn? Do we have obligations to recontact? Do parents themselves have obligations to know information about their children, or do they have rights not to know? All of these things can be sort of wrapped up into informed consent, but all of these issues are still germane, but none of these issues are especially new. The issue that is new and that I'm going to focus our talk today on relates to this notion of incidence findings. So I'm not sure if this is new to people, or if people are in any way in touch with this literature and this challenge, but I'll give you some basics on it. So in all applications of next generation sequencing, there is the potential to recognize and report incidental or secondary findings, and it can be defined in various ways, and that's part of the reason for the controversy. But a basic definition of an incidental finding is a result that is not related to the indication for ordering the sequencing, but may nonetheless be of medical value or utility to the ordering physician or patient. So it's something that emerges from the analysis that is outside the scope of why the analysis was done. So you're searching for an explanation for a child with a set of clinical features, and because of the granularity of the analysis and the scope of the analysis, you also find that the child has a late onset risk for breast cancer. That is an outside the box finding, and that is new to this technology. So the core issue that we are going to discuss and that the community has been grappling with is what to do with these findings once they're generated. So should they be reported? The sort of question underneath that surface is, should they be sought in the first place? And so we'll try to tackle a little bit of that. So just by analogy, if we go back to the apple and the apple slice, is the incidental finding another slice in the apple, or is the incidental finding actually sort of an orange slice entering the scene? And I think a lot of the controversy is wrapped up in to what extent the incidental findings are incidentally generated or are actively sought. And I think we'll try to unpack that a bit. So the genetics and I guess ethics community embedded in the genetics community needed to sort of formulate a unified response to this challenge as it was being faced everywhere, and the laboratory didn't know what to do, and the physicians didn't know what to do, and the community wanted to generate sort of a unified response to it. So they initiated a process. The American College of Medical Genetics is the governing body, it's sort of the largest governing professional body in the United States that sets a lot of precedent in this area. So in January 2012, which is now almost 3 years ago, more than 3 years ago, they struck a working group to try to navigate this issue. They included 16 clinical and laboratory experts. They considered a broad range of disease categories and specific genes, and they developed a set of draft guidelines about how to tackle this particular challenge. They then solicited feedback through an open forum with their membership at one of the ACMG's annual meetings. They revised their principles and their plans based upon the feedback that they received. They then requested additional review and feedback from 15 additional experts to consider what they had put together. And then they, in March of 2013, implemented or notified the community of their recommendations. Through the process, they acknowledged some very sort of specific and important caveats. They acknowledged that their process was based upon the clinical and expert consensus of this working group because the evidence is simply insufficient with respect to what the benefits, risks, and costs of disclosure or non-disclosure are. So they were making a decision from the point of there being really no evidence base on which to operate. They acknowledged that and conceded that that was a limitation. But at the end of the day, we're left with a consensus of, and in many ways, a lack of consensus from a group of experts, and sometimes that's the best you can do with an evolving technology. They also conceded that their group, the 16 and then the additional 15, were not always in agreement about what should be on the list of what they generated. They didn't all have sufficiently detailed knowledge of all of the conditions and all of the genes, and they acknowledged that, of course, their views can't represent the whole community's view. So there was some, sort of the best they could do given the tools that they had, but there certainly has been some misgivings about the process and about how rigorous it was in coming up with the recommendation that they did. So the recommendation, what they ultimately decided was that a list of variants in 56 genes should be reported, would be mandatory to report. So if identified through a whole genome or exome sequence, both were included, considered to be clinical sequencing, any variants identified in that process had to be reported. Just from their sort of recommendation specifically, constitutional mutations found in the genes on the minimum list should be reported by the laboratory to the ordering clinician, regardless of the indication for which the clinical sequencing was ordered. That's their baseline recommendation. A couple of added layers. This was the recommendation regardless of the patient's preference and regardless of the patient's age. So in a space where people are typically comfortable with a lot of preference-based reasoning, where there's a lot of protection around what should be done with minors, they basically took those components out and said, this is what you must do, regardless of what the family wants and regardless of the age of the person of the index case. The way in which they inserted some optionality or preference-sensitive component was to say that you could decline the sequencing altogether. So if you're too uncomfortable with the potential risks of learning incidental findings, then you can say no altogether. So that was their attempt at inserting some optionality into the system. But of course, if you're trying to launch a state-of-the-art, gold standard test, to then sort of take away that opportunity from somebody because they're uncomfortable with some component of it, resulted in some unrest. Okay, so this just at a quick glance to give you a sense of what the nature of the conditions were that were on this list. There were 56 genes, and embedded in 56 genes were a number of different variants. And those genes had specific sort of phenotypic or clinical characteristics attached that could be grouped into these categories. So almost half, about just under half, or a large proportion, were cancer-related. So things like late onset breast cancer, colon cancer, endocrine cancers. In children, there was some retinoblastoma and Wilms tumors, some specific pediatric cancers. So in those cases, there were 23 genes associated with cancer-related syndromes, most of which were childhood onset, or some of which were childhood onset, some of which were only adulthood onset, and some of which could be both onset in childhood or adulthood. A couple of connective tissue disorders, several different cardiac manifestations. So cardiomyopathies are problems with the heart muscle, rhythm defects that could result in sudden death, hypercholesterolemia. So those are thought to be conditions for which there is medical actionability and clinical value to knowing this information, as well as a condition called malignant hyperthermia, which is associated with a fatal response to anesthesia. Yeah.
I'm just wondering if the 810G recommendations apply equally to clinicians using the technology and researchers, and so much of this is still in the experimental space.
They're very specific about this being a clinical recommendation. So in the context of a clinical sequence, a clinical test. It's an important question because a lot of this is in this translational research to clinical space. But in most research paradigms, where they are reporting results back to families, they're having them clinically validated. So it moves from a research to a clinical test in the context of a translational environment that is reporting back to families. So there it would have to align with the standards of the clinical, sort of the clinical responsibilities. And that's where sort of the whole sort of fiduciary duty and obligation stuff comes from. In a research context, researchers are a bit more protected from that. Even in that case, though, there's a lot of pressure and a lot of imperative for researchers even to be disclosing, but there's more protection there than in a clinical context. Absolutely. And it's hard for them to shut off their clinical task, which pushes the obligation to what it's sort of become. Feel free to jump in, yeah.
The patient may refuse, like if you are talking about child and the parents are refusing, but maybe you hide it and the child will never know that there's.
Yes, that's one of the challenges. It's definitely one of the issues. So I think people who are supporting this process think it's important to provide that warning, and if the information is knowable and available, they have an obligation to disclose it if the family should or could act on it. Others would say they've come to your attention to understand why they have autism. We don't need to get into the space of why they might develop breast cancer. Maybe that's something the child should decide when they're older. So that's fundamental to the debate, which we'll talk a bit more about. So what was the logic that drove the recommendation that they generated? First of all, there was tremendous discomfort with masking any form of the informatics analysis. So once the information was generated, there was discomfort in masking whatever was generated. So people will sometimes say, the technology has created the problem. Maybe technology can now suppress the problem. But people have a harder time creating technical solutions to block information than they do technical solutions to create information. So there's a fundamental discomfort with that. There was a belief that the potential benefits of warning parents and patients and families about variants on the minimum list would outweigh any of the harms. So they acknowledged that there were several harms, including the violation of autonomy, the psychosocial distress, or this phenomenon of patients in waiting has accumulated some attention in the literature. We've got this now cohort of children who are now waiting to incur other risks. Contradiction to long-standing policy in genetics where we don't do pre-symptomatic genetic testing, and certainly the lack of evidence base. So they acknowledge these concerns, but their sort of benefit-risk calculus invoke this sense that what we feel and perceive to be more important benefits just fundamentally outweigh these possible risks. So they acknowledged it, but essentially decided that their perception of this benefit trumped any potential harms. They also endorsed sort of the opportunistic screening logic. So with this paradigm, essentially you're creating a screening paradigm. So again, and I'm sort of oriented this from a pediatric perspective, a child is entering the scenario because they're looking for a diagnosis for a set of symptoms, and then because we're now availing to them information about other things. So the ACMG felt that this was an important opportunity, and we as clinicians have a responsibility, and in medicine in general, we do opportunistic screening all the time. So we take a family history, we take a medical history, we ask lots of questions in order to help guide our understanding of what the presenting scenario is, but we use that information in other ways. And any physician would say, if I hear the child's here to figure out why they have autism, but I hear of a significant mental health history in the family, I'm going to make a referral to a psychiatrist. I'm not going to ignore that other piece of information that's been brought to the table. So the ACMG really endorsed that logic and likened it to other medical testing scenarios. So that the imaging world is always invoked in this circumstance, where in the same way you go for a chest x-ray because you've got, shortness of breath or whatever, and you identify some kind of nodule in the lung because it happens to be in the field of view of what the radiologist is reading, that gets reported, and that is standard practice in medical imaging to report those findings. And so they liken this context to that. And so the question that one has to ask is, what is considered field of view in this context? Is the entire incidentalome actually part of the field of view, or are we actively searching for that other field of view? So there's differences in opinion on to what extent this is actually analogous to the imaging context. So as you can imagine, debate sort of ensued from that point forward. And the critics of the ACMG recommendation, as I kind of alluded to, were disgruntled by the fact that this contradicted long-standing consensus regarding genetic testing in minors. So that's been a long-established norm where we don't do pre-symptomatic testing because we don't want to burden that child. We want to give that child their own sort of open future to decide what they want to know about. If there's nothing medically actionable in childhood, we don't need to generate that information. They asserted the idea that violating autonomy is only acceptable if a risk is imminent, and if you're talking about an adult onset risk in a child, that can never be imminent. So we don't have permission to sort of violate autonomy. Offering no choice at all was seen as coercive. So if the only choice is not doing it at all, the critics felt that that was coercive. They were concerned, obviously, about potential psychosocial risk and discrimination if new risks are identified and people end up in this sort of waiting period, or people become less insurable or less employable because of it. This issue of was it a deliberate hunt? So a deliberate hunt, the critics argued, was not the same as an unexpected tumor on an imaging study. The notion of best interest, so the whole principle, the best interest standard, has been brought into this debate quite frequently. And the critics would say, we are concerned about the best interest of the child. We don't care about the parents. We are only focused on the child. So a very narrow view of best interest. And they argued that in a context of insufficient evidence, if we set standards, then liability can easily be misplaced. So standards get set, and that automatically generates, a sense of liability. So if there is a standard, clinicians need to align with that standard, otherwise they're falling below it. And if that standard has been generated from an equivocal place, then maybe that's unreasonable liability to impose. So as you can imagine, the supporters argued that this is a different context from the perspective of testing minors. The longstanding consensus represents a different context because here we have an opportunity to know things about the family that we didn't have previously. They believed in this fundamental obligation to report, and that this trumped any of these potential risks. There was a feeling that soliciting preferences would be cumbersome and expensive and impractical. They endorsed this opportunistic screening logic. They took a relational approach to the notion of best interest. So best interest is not only about a child, or what is in a child's best interest is not just about the child, it's about the environment that the child's in. So if we can warn the mother that she's at risk for breast cancer, that is in the child's best interest, even if it's not about knowing the child's breast cancer risk, knowing the mothers that we've learned indirectly through learning the child, and that is in the child's best interest. And they believe that standards of some sort needed to be set just for the sake of consistency and for getting sort of some structure on an unwieldy space. So in response to all of this debate, the ACMG then revised its policy, and basically in response to the debate, that participants should have an opportunity to opt out of the analysis of medically actionable genes when undergoing whole exome or genome sequencing. So now the ACMG has voted to recommend this opt-out option be introduced into the recommendation, and that in the pre-test counseling phase, participants should be informed of the possibility of secondary or incidental findings and of the opportunity to opt out of it. So they've taken out the sort of all or none component. Now people have a choice about whether or not and what type of secondary or incidental findings they want to receive. So I think the ACMG heard the critics loud and clear. I think they recognized in setting up the recommendation that they were walking into a bit of a minefield with it, and then fairly readily, without a lot of to-dos, reshaped the recommendation that made people much more comfortable.
But if you opt in, is it still the same 56, or can that be?
So the same 56 is what is, the labs are obligated to identify, and then individuals can choose yes or no to the 56. I think whether or not they can choose all or none, like if they have a menu-based approach to the 56 versus if you say yes, you're saying yes to all, I think that varies by lab. I think some environments will give patients the opportunity, for example, to say, I want to learn about everything cancer, but nothing else.
Because it's not feasible to allow them to choose individual 56 is a lot of counseling.
Yeah, absolutely.
And do you know whether these this is information that the patient does not receive, but the doctor does? Or is it
if the doctor receives it, the doctor will report it. So doctors don't want to be the gatekeepers. The laboratory, and that's very sort of loud and clear. If the patient has expressed a preference, it will be communicated from the lab to the doctor to the patient. If the patient has said no, then the lab will hold it. It stays in the lab.
Because, I mean, for me, this, except from the clinical importance of that direct clinical guiding treatment or prophylaxis, it also serves a research purpose, this information. And I mean, even if this is not used for deciding at the moment, I mean, it would be possibly a useful thing to have a repository of this information.
Absolutely. So I think the labs will retain, I think it actually varies. I think, for example, at ScKids, if patients choose not to have it, the lab doesn't look. They don't do that next step because it's cumbersome, expensive, resource-intensive to do it. So, but they have to struggle because from a discovery science point of view, of course, they want to look. So it depends on the aims of the entity doing the sequencing and doing the analysis. They still have the DNA, for sure, and that brings up a whole set of issues around duty to reanalyze and recontact. Yeah.
It seems to me that if the information is available, if the patient chooses not to receive it, that there are certain key points in life in which any physician or anybody treating a patient, for instance, potential surgery, where that might become relevant to the success of the surgery, that somehow should be that there should be some way of notifying that surgeon that surgeon should do a scan to see whether any of this stuff has been done to that particular patient at that point.
So some people would say that eventually genomics will be that sort of bioinformatics tool that clinicians can surf for any of those purposes in a given situation. In a NICU, in a surgery room, what does the genome say and how does that direct traffic here? We're not there yet. So at this point, that kind of contextually relevant information is not going to be available. There isn't the infrastructure to make sure it's available when it's needed. And in most cases, I don't think, the clinical labs aren't going to generate the information unless the patients have asked for it, because they don't want to be on the hook for holding on to it. They don't want to use the resources to do it or be on the hook for holding it without disclosing it, because that creates a liability for them.
It's still that medical directive, right? Like, who decides as a patient? Like, it's not like anybody can go and say, I want to. It should be driven by an indication.
Absolutely. So different environments will have different eligibility criteria for whom it's appropriate. And generally they are, diagnostic quests that are driving it. And in that situation, the primary purpose is to understand what, the cause of the presenting set of features. And in addition, if families want this other information, then that's made available to them. But it's certainly not at the level of your family doctor or the worried well. And if and when it goes there, I don't know. It's hard to say. People would have very differing views on if and whether and how. So to me, the elephant in the room on this whole debate is always sort of the question of, are these incidental findings truly incidental? Or are they part of a comprehensive analysis that we can't avoid? So there's obviously sort of two camps on this. The people who see them as truly incidental are sort of, there is sort of the camp that sees them as part of a comprehensive analysis, in which case they are not incidental, but I would say they're sort of more secondary or additional or ancillary. So the McGuire camp that sees this as all part of the same apple, the analysis of clinically beneficial incidental findings is integral to the primary interrogation of whole genome or exome sequencing, constitutes a single comprehensive assessment using complex analytic algorithms for interpretation. So that camp sees this as one test. Whatever it generates is what we're obligated to report. The other camp that sees this more as an orange slice says no, the genes relevant to the patient's clinical presentation can be analyzed without including the 57 gene panel that the ACMG has recommended. So they see it as a deliberate add-on to the analytic process. So resolving this, I think, is fundamental to the debate. I think we've sort of resolved, if the findings are generated and possible to generate, we know what to do, we offer a choice, and we disclose what people have chosen. But whether we should actually be identifying these remains a little bit unresolved. So as we know, Sequencing of any sort involves the analytic sequencing phase of generating the DNA code for any one individual, as well as a bioinformatics filtering step that makes sense of that sequence. So even if the disease gene has been sequenced, a variant isn't actually identified until it is revealed through the bioinformatics process. So you can have a whole alphabet soup of sequence, but until a bioinformatics filter has been applied, you can't make sense of what you've generated. So what is included in the analysis versus added onto the analysis depends on how that bioinformatics pipeline is set up. And people are setting up those pipelines in different ways for different purposes. So we have the McGuire camp, who's setting up the pipelines in very gene discovery-oriented ways. So they see it as an opportunity for research, for discovery, for understanding what's there, to generate, improve our evidence base on what all of these genetic variations are and how they're associated with various phenotypes. So they cast the net very wide and see and set up their pipelines wide, so all is caught. Whereas other and typically more clinically oriented laboratories that have a clinical mandate to provide a diagnosis, to have a high detection rate, not focused on discovery, tend to be much more tailored and targeted in their bioinformatics pipeline. So they'll say, our population is oriented to autism. We want to pull and annotate all the genes that could possibly touch the autism space and not really think about the others. So in that context, they're much more targeted. And in that context, the BRCA finding suddenly becomes an add-on, because that wouldn't normally be included in their more targeted clinical panel that's oriented around identifying autism causes. That distinction clear? Okay. So that portion of the debate is really kind of unresolved, and I think people have just accepted that there are different designs and they're designed for different purposes, and we're trying to do something sensible with all of the competing interests. So part of the challenge is in language and is in definition, and I think we need to work on the clarity of all of that. So the U.S. President's Commission for the Study of Bioethics has suggested one sort of set nomenclature, which I think actually makes a lot of sense. So they define primary findings as variants directly related to the primary disorder that prompted the testing. Incidental findings are those that are unrelated to the primary disorder, but unintentionally discovered despite the focused nature of the test, which really is sort of truer to the word of incidental. Secondary findings are those that are unrelated to the primary diagnosis, but specifically sought. And then discovery findings are those that are found by high bandwidth tests that are purposely designed to detect variants in a wide range of genes that are related and unrelated to the various disorders. So I think this kind of nomenclature helps people be clear in what they're describing and what they want to do going forward. Okay, so just to sort of shift gears to real time at SickKids, where we're sort of grappling with this and have implemented a structure to do this. The Genome Clinic is a fairly new clinic at SickKids that provides whole genome sequencing to a pediatric population that meets certain criteria. Typically, the kids have any combination of autism plus or minus some congenital anomalies. They're doing a comparative test, comparative study looking at the performance, costs, health service outcomes, ethics of sort of whole genome sequencing compared to traditional techniques like chromosome microarray. This is the Genome Clinic's workflow. I'm not going to take the time to go through it, but basically they get referred to SickKids. If they meet these criteria, they go through whole genome sequencing. They have a very careful phenotyping process. They do the conventional tests. They are disclosed. Primary findings are automatically disclosed, anything that's diagnostic. Anything that's medically actionable in childhood is automatically disclosed. And anything that is considered medically actionable in adulthood, parents have an opportunity to choose. So we've embedded a choice-based model, and that is the decision point. So where it is adult onset, that's where there is a choice. They are only disclosing things that are medically actionable, whether they are. There's also sort of this whole zone of uncertain results that aren't really part of the conversation. Anyway, so that's the structure, and this whole sort of translational design is hoping to improve the diagnostic tools, improve our clinical systems that manage it, inform costing and health services analysis, and try to generate some good evidence to create some favorable and sustainable policy in this area. So I've just sort of touched on the cohort of kids that are enrolled. They get referred from all over, sick kids from the community. If they meet these criteria, they are eligible to enter the study. Just to talk through a little bit more granular how the decision points are inserted in the process. So they enter the study, they have genetic counseling, they go through an informed consent process to describe to them what whole genome sequencing is all about. They make an active decision at that point about whether or not they want to receive secondary medically actionable variants that are adult onset. They have the genotyping process. We are very explicit about the fact that in this context, this is an active hunt for additional findings. So the group at Sick Kids feels the same sense of obligation, fiduciary duty, opportunity, discovery science, driving factors to be as comprehensive as possible. We're explicit with families about that, but then we give them a choice about what they want to learn. Once the results are available, the families then have an opportunity to reaffirm the decision they made earlier. So we want to think of consent, informed consent as a process, not as a time-limited or sort of a one-time discrete event, but as something that can evolve over time. So we give them an opportunity to change their mind.
On track for conversations, but how do you obtain consent from minors, or is there a protocol that varies as the child gets older?
So it's a parental decision unless the child,
One parent, one parent.
at least one. We hope for consensus between the parents. I don't think there have been too many cases where parents have not agreed. Where the child is considered a mature minor, and that's not age-based, that's capacity-based, an assessment is made, and if that child sort of meets those criteria, then the child can make the decision. Will that change over time? The group has not really entertained the whole issue of reanalysis and recontact. So it should evolve as the children gain in maturity. If they've chosen no, maybe the children should then be brought into that decision as they get older. Probably we'll get there, but at this point. So just back to sort of the opposition support debate, the Sick Kids approach really lands in the support side of the ACMG approach with a specific focus around best interest, and a specific focus around best interest operationalized as relational. So the group at Sick Kids feels very strongly that a child's best interest is inextricably linked to its family, and we need to be thinking about this from a relational, familial perspective. So just some conceptual work around the notion of best interest. Lots has been written about this standard, how we define it, how we shape it, how we implement it. It's not a clear-cut concept, but certainly there are a number of dimensions to it. Some people oriented this best interest as sort of a self-regarding concept. Others relate to it as an other-regarding concept. It can have both cognitive and emotional components. There can be both present-oriented and future-oriented interests. So it's a constellation of concepts, the best interest standard. And again, as I said, in our environment, we've oriented to it as a relational one. So in the same way we've discussed the BRCA finding from the ACMG perspective, the feeling at Sick Kids is that this avails an opportunity that wouldn't otherwise be available to the family to identify a future risk in the parents. So that is in the child's best interest. I've talked a bit about this. I feel like I'm going to run out of time. So those findings that are medically actionable or pharmacogenetic in a pediatric context are automatically disclosed. There's no choice there. There is choice about what happens in adulthood, and we give people sort of this menu of categories from which to choose what types of results they want to have. And then, as I said, we give them an opportunity to reaffirm that choice. Yeah.
If you go back to this slide here, I mean, the notion of risk is not very directly translated to whoever's making the decision by a table like that.
You're right. No, you're right. This is a paper version of a conversation. There is a quite extensive education and consent and counseling process that is a better representation of this chart. So they have a sustained dialogue with a genetic counselor. Often it takes several days or several phone calls before they come to a decision. You'll see from some of the preliminary results that for most people the decision is fairly quick and easy, but it's certainly not a paper-based process.
Yeah, but so the notion of uncertainty in this risk, do you think that is being taken into account from your experience? I mean, there is uncertainty on the evidence that they support
Absolutely.
all of these relations and
Absolutely. I think generally people are either information seekers or not. And if they are information seekers, they are willing to take uncertainty with that information. So partial information or uncertain information is still preferred to no information. Other people are really, I'll cross that bridge when I come to it kind of people. I don't need to know what isn't relevant to me now. I'm focused on my child's health right now, and cancer is just not on my radar. My plate is full enough with what I'm managing, so no thanks. But it generally, and I think the uncertainty does trip people up a bit, but I think they tend to be one type or the other. There isn't a lot of ambivalence. Yeah.
I think there might be a third type, and those are people who are information seekers, but they're not information seekers to the point of where they eventually tell the children. They want to keep it from the children and when they're minors and they're being tested. Parents will know, but the children will never know. And that presents an ethical problem in later in life. The information has been provided to the family at some point, but what do they do with life insurance? And there's an obligation to disclose to a potential insurer if the person applying is now an adult, never knew this information, but yet the information was somehow available to them in some way or form previously.
It's a challenge. I mean, you hope these kinds of structures engage families, so you have ongoing communication. You hope that you remain in contact with the family so you can sort of follow their wishes and their context over time. But that's a risk. It's definitely a risk. And in any sort of pediatric context, we're putting a lot of stock in the parents to sort of make and then inform their children of these relevant things.
And so there's no compulsion on parents to ever, that's ultimately their choice, what they do with that information in terms of within the family.
There's another whole set of debates around, how far does the clinician's obligation have to go in terms of duty to warn? I mean, there have been messy legal cases where physicians have discharged that obligation to one family member, but that family member has dropped the ball, either deliberately or not, on telling other family members at risk, who then incur risk. And so is the clinician responsible for disseminating to the entire family structure? Does that breach that index patient's confidentiality? Or do you have to place some responsibility on the family? But either way, there's risk.
How long is an average counseling?
We're trying to track it. It tends to be, I think it's broken into a couple of pieces. I think it tends to be about an hour at first blush. Then there's probably 1 or 2 30-minute follow-up phone calls. Seems to be about how it's going. And again, I think people are not stewing as much as we thought they would. And I think tends to be, this is an academic tertiary care center. Parents who are coming are empowered information seekers.
Some children whose parents are not interested in knowing about the results have access to their results.
Good question. We don't have an established policy yet. I think at the moment the numbers are few, but I think, so don't know yet. We need to create that because that will come upon us. At the moment, the obligations are such that the families are told, here's what we have for you now. Stay in touch with us for new information. This will change. Our understanding of it will change. You need to call us. We'll answer your call anytime you call and tell you what we know, but we won't proactively contact you with new information. That's the current standard, that there isn't an obligation or duty of recontact in sort of the field right now, because it's just, you can imagine how cumbersome and unwieldy that is, and resource intensive. But if families initiate it, then that information is available. Okay. So really quickly, 321 families have been approached to participate in the genome clinic, and 45% have declined, which is quite interesting in itself. I think it's much lower uptake rate than people anticipated, Whether or not that's because, well, so we have a little bit of data on why. It's hard to know exactly why, whether it's sort of the secondary findings is scaring people off, whether they're too consumed by their child's health, or a combination of things. So we have some very basic data on why people are declining. About a third are concerned about insurance discrimination. So this is declined participating in the genome clinic altogether, not just declined receiving sequencing results. So this is an even more sort of disinterested group of people that doesn't even want any part of the process, perhaps because there is some of this risk attached. So about 30% are concerned about insurance issues, about 30% are concerned about psychological distress, about 20% say it's just not the right time, and about 10% describe some combination of these reasons.
And this is after counseling.
Pardon me?
After counseling.
So they haven't even gotten as far as counseling.
So
They know what
basically
they're
just the healthcare provider offered genetic counseling
Yeah.
and they rejected it,
Yeah.
like declined
Yeah.
at that time.
Yeah. There is similarly, I mean, the reasons for those who also choose not to receive secondary findings, the numbers are similar. This is a demonstration of those who do participate, their preferences around the secondary findings are the following. So about 60% want to learn everything, but as many as 40% do not clearly want to learn everything. So this sort of information seeker, non-information seeker, there is a substantial portion, I think, again, more than people thought, of people who don't want to know. And I think it's hard, and qualitatively we're trying to get at some of these reasons, but I think parents are fairly overwhelmed by the nature of the illness in their child and don't have a lot of extra energy for other things. So bottom line there's sort of no clear consensus on what people want to do with the secondary findings. But those who do want to know, back to the table that we asked people to figure out, those who do want to know typically want to know all there is to know, which is not surprising. So how are we trying to understand how parents and healthcare providers are sort of reasoning through all of this? So we've done a qualitative sub-study both with a group of parents and a group of healthcare providers who are invested in this process. So far, we've spoken to 25 parents who've chosen to participate in the genome clinic and have made slightly different decisions around the secondary findings issue. We're planning to interview them again once they receive their results. That process hasn't happened yet. And we've also interviewed about 24, I guess, healthcare providers, half of which are sort of what we've described as genetics invested, so people referring to the genome clinic, and half of which are sort of more generalized physicians in the hospital who are not as invested in the technology. Asked the parents semi-structured questions around their understanding and expectations of the technology, their experience with the education and consent process, and their reasoning around the secondary variance issue, and asked healthcare providers again about their experience with the technology, what they perceive as facilitators and barriers to using it, their views on the ACMG process, and how they orient to the notion of best interest. I'm not going to take the time to review those demographics. From the parent population, we see that the majority of those who are enrolled in the study, in our sub-study, want to know all the secondary variants. Only 18% want to know some. The majority that are invested in the study do want to know. What is their reasoning? Of course, they're balancing sort of what they perceive as some pros and cons. The elements that engender support are the potential for prevention, further diagnostic and prognostic clarity. So even if it's related to something unrelated to the presenting symptoms, families think, well, maybe in some way it is. Maybe there is some risk related to something in the future that is related to this target condition, and they're eager to contribute to the development of the technology. Those who are more ambivalent are concerned about the distress, about insurance, and struggle with this sort of knowledge, inflicted insight versus valued insight notion. So these are just a couple of quotes you can read. So we have the tools for prevention. My child might be prone, I might be prone myself. Ambivalence, someone was really sort of quite strong in their language. He has pretty much a guillotine hanging over his head of all these possible things that could go wrong. So what's the point of living if you've got this guillotine hanging around your neck? In the future, if I decide to take out insurance, my costs are going to skyrocket. And then sort of the tension with the insight, we only want a bit of secondary findings. We don't want to know everything. The world is full of things we don't know and understand. Some of that is where the rub of life is. So someone who's clearly happier not knowing all there is to know. From the provider's perspective, the notion of best interest is clearly relational, clearly thought of as relational. The genetics world tends to think of itself as very oriented to the family in defining and understanding and orienting to the notion of best interest, but clearly all pediatricians do too. I think that is an important finding, is that it's not just geneticists who feel that the family is sort of relevant to the child's best interest, but unanimously, really the pediatricians who are not so invested in genetics felt very taken, and sort of this notion of relational best interest definitely resonated. So despite the support for that best interest and despite a sense of obligation to report, there was definitely also some unease around breaking sort of long-standing consensus and policy. So it felt to them that we're sort of breaking the rules, and also some discomfort around the uncertainty with the promised benefit. So yes, while in principle you think the mother will go have the mammograms and have the mastectomy and be alive for her child, what if she doesn't? What if she does something irrational and it actually turns out to be not in the best interest of the child? And we just don't know. We don't have evidence to support that one way or the other. So they struggled with a little bit of that, with that uncertainty, but still needing to make a decision despite it. So just some lessons, quick lessons that we've learned, that does seem to be a lack of consensus regarding learning the secondary variants. There is support. The concerns are largely lie in sort of the psychological distress, insurance discrimination box. Support also from providers because best interests are thought of as familial, but some concerns around breaking the rules and uncertainty related to evidence. And then another sort of, I guess, argument or conclusion from this is that while things remain somewhat unsettled, a choice-based model does seem to align with both the ACMG guidelines and with the general tenor of the community and the stakeholders that we're serving. But obviously we need to do some more long-term follow-up work to understand how all of these outcomes play out. Since I'm speaking to an economics audience, I couldn't help but throw in this slide, hot off the press paper from one of you. It's part of this community. I'm sure many of you know Dean Regier, who's now in Vancouver, and he's just published a discrete choice experiment looking at societal preferences for the return of incidental findings from clinical genomic sequencing in order to try to quantify this notion of personal utility. And I think it's a really important paper and a really important direction for research to go to try to understand qualitatively, but also obviously to quantify what this notion of personal utility means. And interestingly, I think it's interesting that his findings were what they were. So he did this DCE with 1,200 Canadians. Participants valued receiving variants of high penetrance, but expressed disutility for receiving variants of low penetrance. And while they were willing to pay $445 to receive these results, the models they did predicted that only 66% of people would actually do this. So I think there's clear ambivalence. Yes, preference-sensitive stuff is probably the right approach, but it's not a slam dunk that everybody wants or believes this is valuable. There was no pediatric content to this particular DCE, so I think that would be a really logical next step. So just to conclude, obviously we are in the space with lots of opportunity and lots of challenge that we're forging ahead with. One question, should a technological revolution that we're experiencing be accompanied by an ethical one? Should our ethical standards and paradigms and norms shift in accordance, or should they remain static and stable? Are preference-sensitive models feasible and affordable? How we actually do this sort of very granular work. And are patient preferences the best way to govern the use of complex and evolving technology? I think there are differences in opinions on whether or not the patient choice should govern how we use this, or whether we as payers and technology designers should create structures to govern them either the same way or differently, but whether or not it all relies on the patient, I think is still open for question. So just to acknowledge the clinic, the ethics team that's attached to the Genome Clinic at SickKids and the Center for Genetic Medicine, including the people here, and Wendy and her team for integrating themselves into our work. And that's all. Thank you.
this was really fantastic talk. Thank you for that. You sparked definitely a lot of interest. So we have a couple of minutes for a few questions.
What do you see the impact of some research in the future about the impact of lifestyle on this kind of
Findings? Yeah, I think it's important. I think to what extent it changes health-seeking behavior, to what extent it changes diet, exercise, those kinds of lifestyle things. I think that's important work, that some of it has started, and there's varying results. Both, they're mixed. Some studies are finding that people do alter their health-seeking behavior and their lifestyles, and some are saying they don't, which is not surprising. I think there's sort of the fatalism versus empowerment argument. So people say, if I'm genetically predisposed, there's no point trying to alter my diet. And others will say, well, if I know I'm genetically predisposed, then that empowers me to change my diet because this is a multifactorial trait. So I think the evidence isn't clear. I think it's important to gather.
It also be helpful for education.
Yeah.
So, I mean, as a society, we're certainly getting into big communities are getting more used to the idea of risk. A lot of our newspapers about genomics are kind of getting a sense of their risk tolerance, and also getting a sense of what it means to have uncertainty.
Mm-hmm.
We're also investing in gadgets that measure everything for something.
Mm-hmm.
To what extent, through your qualitative research, do you feel that parents' preferences are static or dynamic? And one of my concerns with the choice experiments is that at best they're snapshots.
Yeah.
Preferences given the societal context.
Yeah.
And that.
It's a good question. I think they're probably dynamic, and I think they are context dependent. And life's contexts change, and the family and children's needs change. And I think the relevance of certain information will vary over time. So you're right, that's a limitation of something like a DCE in this context. But it's also hard to capture that change over time, even from a qualitative perspective. Yeah.
What's the lay of land across Canada when it comes to policies? Are there similar to kids?
So I would say Sick Kids has evolved to be quite unique in its active hunt for more. More environments are being restrictive, I think largely because they don't have the resources to be more expansive. So to do a more expansive analysis and to make secondary variants available is obviously more resource intensive. And these translational centers are grant supported, and they don't have the capacity to be as extensive. So I think they are both more conservative and also more limited in their resources. I think Sick Kids sees this as an opportunity and wants to push the boundaries and has some capacity to do so. So there's an active group in Vancouver, there's an active group in Quebec, there's an active group in Alberta, there's an active group in Ottawa, and they're being more targeted and tailored what they're willing to report back and seek out.
What's the current process in Sick Kids with respect to data collection? I mean, do you keep a registry that you use it only for
the actual sequence data?
Yeah.
So yes.
So the findings from this.
Yes. They will be retained, and we have the capacity to reanalyze the sequence. We don't yet have the policy or the resources with which to do it.
What about the current results, for example? How long do you keep the current results?
That's a good question. At the moment, you know what, that's a lab QA issue. I don't actually know what the rule is at Sick Kids, probably indefinitely at this point. But it becomes a storage issue. I mean, it becomes definitely a data storage and infrastructure issue. Yeah, after consent. I mean, the hope would be to keep it forever. The genetics, the laboratory people would not want to let that go. But and I think it's still manageable from a data storage perspective.
And my question is not from a data storage perspective, it's more like whether research is going to be targeting this data in the future as well, and linking this data with isotope, for example.
We'd love to. Yeah. Exactly. No, there's absolutely. We're baby steps in that direction of trying to define.
The ethical considerations along with these kind of baby steps are really big.
Yeah.
Oh, for sure. Because who has access to it,
Yeah.
right?
Yeah. Yeah.
If you are open, like you are giving it to patients, but then you are giving it to researchers as well.
But there is sort of a step between the raw sequence data and the filtered, annotated, meaningful, interpreted analysis. Mm-hmm. I mean, the PGCRL is filled with sequencing data. I don't know how they're dealing with it. I'm sure there isn't enough of anything.
Any other questions? Or we can, I think we all would be.
Yeah.
Okay. Thank you so
Thank
much
you
again
for
for
being
being
so